Hello, students. We being the frontline warriors in the current pandemic, so we need to take all those possible precautions, and I hope you all must be observing them, and you all must be taking a very good care of yourselves, right? So, in my previous video, the link I am providing below, we talked about that, our diabetic patients, they have this propensity to develop chronic kidney disease, and we learn that most of the times this chronic kidney disease is because of diabetic nephropathy only, though uncommonly in clinical situations we do come across a diabetic patient where the kidney disease is not because of the diabetes per se, that is not due to diabetic nephropathy. He is having some other kidney involvement. And if you recall, we discussed that this differentiation, that whether this diabetic patient is suffering from diabetic nephropathy or some other kidney ailment, we can easily distinguish by looking for the speed of development of the kidney disease, by analyzing the urine, and lastly by looking for the retinopathy, right? So do go through that video discussion. Now I would like to further clear some of your important questions here. For example, this question number one, diabetic nephropathy patients are predisposed to, so there's a fill in the blank, during later stages of CKD. So what do we need to fill here? Diabetic nephropathy patients are predisposed to hypoglycemia or hyperglycemia during later stages of CKD. Well, I'll come back to this question. Let me ask you this question. In physiology, you must be aware of this. What is renal threshold of glucose? Well, some of us, do a little mistake over here. I know you all are, saying that it is 180 milligrams per deciliter, more than or equal to 180 milligrams per deciliter. But just, I want to clarify this concept of yours. We all know that, across the glomerular capillaries, this glucose being a very small uh, molecule freely filters down, right? But the thing is that the tubules are going to reabsorb this glucose back into the circulation, right? But when this plasma glucose goes beyond 180 milligrams per deciliter, then the rate of filtration of glucose molecule exceeds the rate of reabsorption of the glucose from the tubules. So then this glucose starts moving ahead into the nephron, and finally it is out into the urine, right? So you can say that we have a safety valve here, right, in the kidneys. And if the plasma glucose is going to rise above 180 milligrams per deciliter, then as I said, the rate of filtration will be more than the rate of reabsorption, and therefore the glucose will start moving ahead into the nephron, and ultimately it will be going out into the urine. So going by this logic, you will think that diabetic nephropathy patients during later stages of CKD, when the GFR has drastically gone down, say this patient is now into stage 4 CKD. We all understand stage 4 CKD means a GFR below 30 ml per minute, or say he is into end stage renal disease now. The definition we all understand, that is less than 15 ml per minute. So whatever the case, the GFR has drastically fallen down, and some of us can apply this logic that the glucose is not able to filter down now because there is a shutdown here. The GFR has gone down, and as a result, the glucose is persisting in the circulation. So maybe the answer, the choice to be filled up here is is hyperglycemia. But going by this physiology logic, the answer will be wrong. The right answer to this question is that diabetic nephropathy patients are actually predisposed to hypoglycemia during later stages of CKD, and I'll explain how this hypoglycemia happens to them. Well, you must have learned that where does this insulin gets catabolized in the human body? Well, 50% of the insulin gets catabolized inside the liver only. You must have read this in pharma. So you call it, a very high first pass metabolism, right, going on. And what happens to the remaining? So as soon as the insulin is getting released from the islet cells and then through the portal circulation, the insulin is reaching into the liver. So 50% of it gets catabolized. Now, what happens to the remaining 50%? Now, this remaining 50% of the insulin, remember, it gets largely catabolized into the human kidneys, right? And how it happens, like, again, insulin is a small proteinaceous hormone, so it also gets freely filtered across the glomerular capillaries, and once it is present into the tubules. So if you recall my second or probably third video discussion with you, that whenever some protein reaches here, we were discussing albumin at that time. So what happens to these proteinaceous molecules over here, that these tubule cells, they tend to digest, they tend to break down these proteinaceous elements here, and then ultimately the amino acids are absorbed, right? So insulin gets catabolized in the normal kidneys. So what happens when a patient of diabetes goes into diabetic nephropathy, and with the declining glomerular filtration rate, now this insulin also is persisting into the circulation for long, right? So you need to remember this, that the half life of insulin gets prolonged in a diabetic nephropathy patients, in the later stages of CKD, when the GFR has fallen down drastically. And as a result of this, since the T half of the insulin is now high, so insulin is persisting in the circulation for long. So therefore, these patients, they are actually predisposed to hypoglycemia uh, in the later stages of CKD, right? So the right answer here is hypoglycemia. So if you have imbibed this concept, we can discuss few more important questions. Say your uh, just a sec. Yeah, your type 1 diabetic patient is now advancing into CKD due to diabetic nephropathy. So what would you like to do with the insulin dose? Yeah, so you are right now. So you need to reduce the insulin dose into your type 1 diabetic patients. So remember this, that typically these type 1 diabetic patients, they are on insulin only. I mean, this is the drug of choice only. Uh, and in insulin, I mean, this is the only thing we can do to them to control the blood sugars. So typical insulin dose in these patients is 0.5 to 1 units per kg body weight, right? So when these patients, they are advancing into diabetic nephropathy, we need to reduce this dose of insulin. Otherwise, the patient will be landing up into hypoglycemia. So as the patient keeps advancing into the CKD, you need to further, reduce the dose of insulin, right? And similarly, what about this question? Your type 2 diabetic patients is nearing end stage renal disease. Now, what is the drug of choice to control hyperglycemia? Well, in the previous question, we saw the question was asked with regard to diabetes 1, type 1, and here insulin is the only drug available to control hyperglycemia, but we need to reduce the dose of insulin. But in type 2 diabetic patients, initially we start these patients on OHAs. Here, you need to know that when a type 2 diabetic patient goes towards end stage renal disease, then most of these OHAs, they are contraindicated. Only few of them, we can give. and this is a separate topic of discussion, and I'll take this topic probably in my next discussion. So do go through any of your textbook of medicine and find out which drugs are contraindicated and which OHs we can continue towards the end stage renal disease. But the answer to this question, what is the drug of choice to control hyperglycemia? Remember that when a type 2 diabetic patients are advancing towards end stage renal disease, then the drug of choice to control the hyperglycemia is insulin. Right now, in sharp contrast to our type 1 diabetic patients, as I said, where the typical insulin dose is 0.5 to 1 units per kg per day, here in type 2 diabetic patients, we start the insulin at a dose of say zero point 0.3 units per kg per day. The reason being, here we have an absolute deficiency of insulin. We all understand autoimmune beta cell mediated destruction of islets have already happened, and here in type 2 insulin resistance is largely the issue, and therefore the insulin levels are still there in the human body. So here the starting dose is zero point 0.3 units per kg per day. But when a type 2 diabetic patient is nearing end stage renal disease, and the OHA is being largely contraindicated, and we have decided that okay, insulin being the drug of choice, so let us introduce insulin to the patient. So we would not like to start with 0.3 units per kg per day as a typical dose. So we'll start with say zero point 0.1 units or say zero point 0.2 units at the most to start with, right? So as to avoid this hypoglycemia complication to happen, right? So I hope you have again learned some very important concepts, and again, the same recommendation from my side, that you enjoy reading your ENT for entrance exams book. This is a one-stop book for all your ENT queries, right? So all the best, and take a very good care of yourself.